Okay, good evening all. I'm Rohit Kotawde. I'm working as a senior product executive at Derma. I'm welcome you all for the Dermapath Academy and Diagnosis Indian Private Limited presented analyze real world dermatopathology cases and educational support by Gloderma. This is the 9th lecture we have conducted. So before give a introduction about the Gloderma, I would like to thank you to Dr. Sasi sir, Dr. Nandakumar sir, and Dr. Manoj sir to giving an opportunity to present here. So now I would like to introduce about the Gloderma. So the Gloderma have a core purpose that is elevating life, and the core value is meaningful innovation, unwavering commitment to the quality and safety, continuous improvement, and result through teamwork. Also, we have an aspiration core value that is customer success above all else. So Gloderma have a successfully launched 7+ first-time Indian brands. Along with that, we have a 400+ enterprises Glodermians and 113 ranked pharma company in the country. Gloderma have a 700+ distribution network and 9,000+ associated dermatologists. Gloderma have a skilled R&D team and develop innovative products. Gloderma have a product mix like a antifungal, moisturizer, acne care, and hair care. Along with that, we have a psoriasis care, topical steroid, vitiligo care, and nutraceuticals. So Gloderma is India's first company who make all product paraben-free, sulfate-free, and detergent-free. So patient safety is of paramount concern. Now I would like to introduce about our flagship brand that is Moist, clinically proven range of moisturizer and cleanser. So Moist is a non-comedogenic, non-irritating, and skin-friendly paste. In Moist, we have a gentle cleanser that is Moist cleansing lotion and Moist scented bar. Along with that, we have a moisturizing cream that is Moist XL and Moist XL Lamitube. Along with that, we have a Moist MM and Moist LMF 48 lotion that is long moisturizing lotion. Along with that, we have a ketoconazole range that is Kion, the most advanced range of ketoconazole. In that, we have a Kion Stay-On lotion, Kion soap, Kion zip, and Kion cream. Also, we have introduced a new improved version of Minoboost that is containing minoxidil topical solution and tablet, the complete hair regrowth therapy. In Minoboost, we have a Minoboost 5, which containing minoxidil, plain minoxidil. Minoboost F5, which containing minoxidil 5% and finasteride 0.1%. Along with that, we have Minoboost F5, which containing minoxidil 10% and finasteride 0.1%. And we have Minoboost Progain. Also, we have a oral therapy that is Minoboost 2.5 mg tablet. So Minoboost Extra Boost for the faster hair growth. Also, we have a range of KeraBoost that is the unique hair growth booster that is KeraBoost tablet, which is enriched with the D-biotin, N-acetyl, and L-cysteine, and which made by the IDDS technology for the site-specific 3-phase. So KeraBoost tablet available in Trichology pack along with the Stripe of 10 tablet. So boost hair growth, boost confidence. Also, we have a autoimmune skin disorder range. The management of autoimmune skin disorder, we have a Facetinib ointment, Facetinib XR tablet, which contains Tofacitinib 11 mg tablet, and Facetinib tablet, which containing Tofacitinib 5 mg tablet. Also, Gloderma have a tie-up with the Sanosun Baby, made in German brand, premium pediatric skincare segment. So, Gloderma have an international collaboration that is Man & Shoulder, bring world-class derma tested certified with the natural and safe baby skincare products to Indian mothers. So Sanosun Baby made in Germany, German's premium baby skincare. So one global, one formulation, 40+ years of expertise in baby skincare and presence in 70+ countries. So Sanosun Baby made in Germany gained the trust and confidence of 2.5 lakhs of Indian mothers. Sanosun Baby made with a more than 90% natural ingredient, 0% SLS and SLS free, and clinically tested hypoallergic. Sanosun Baby with a milk protein and organic olive oil. So that's all about Gloderma. Thank you. Now I would like to hand over session to the Dr. Sasi sir.
Thanks, Rohit. So thank you very much for the Gloderma team for kind introduction and support. So today we're going to kickstart this 9 CPC session. Dr. Nandakumar sir and myself are here. So we have a special guest, Dr. Sharmina, today, who is going to be here, and we're going to go through the cases with Dr. Sharmina. Dr. Sharmina, do you want to switch on your camera, please, so that we can introduce yourself?
Yeah.
And
Can you see me? Yeah.
Yes, yes.
Good
So can you
afternoon.
briefly introduce yourself, please? I think you came on to the session a few weeks ago, but you couldn't
Yes,
stay for the entire session, right?
yes. I couldn't. So I'm Dr. Sharmina. I work in Dubai. I've been working here since the last 8 years. I did my post graduation in Kerala from Calicut Medical College. Um, and I've always been interested in Dermpath, but I've never got around to actually hardcore reporting. So I would like to increase my, um, hands-on reporting skills. That's why I decided to sign up.
And you're a pathologist, right? Or you're
I'm
a
a
dermatologist?
histopathologist. I'm a histopathologist.
You're a
Yes.
histopathologist, right?
Yes.
Okay, welcome. So we have 7 cases today, so we'll go through them one by one. And since you're the only person free today to sign up, so you'll have the full attention, and you can go through each and every case. But it'll be an informal thing, so don't worry. Nandakumar sir, are you happy to take on the first case? Shall I share my screen?
Oh, sure. Go ahead.
Okay. Let me share the entire screen. Okay. So hopefully now you can see everything. You can see my screen, right?
Yes.
Okay. So the first case is an 18-year-old female who was complaining on the lesion of left cheek since 5 years, and 4 to 5 episodes of bleeding on manipulation and progressing to present size. So she had 3 to 4 skin-colored erythematous verrucous plaques on her left cheek, and the the clinical differentials given were verrucous epidermal nevus, verrucous hemangioma, lymphangioma, circumscriptum. That's spelling mistake. So this is the clinical photograph. This cannot be zoomed, but you can make out. It's there's a plaque here, a slightly warty lesion, warty plaque on the cheek, brown color. So that's the clinical image. And this is the histology image. So I'll go to this section, which seems to be reasonable. So Nandakumar sir, all yours. You can guide Dr. Sharmina through. Nandakumar sir, are you there? Oh, you seem to have lost him. Are you there, Nandakumar sir? Okay.
No, sir. Actually, I guess he has a facing network issue.
Okay. So Dr. Sharmina will start off. Maybe you want to start describing this. What do you think of this
Yes.
low power? Start with low power. And
My
then,
internet is also sketchy, doctor, but you can. Yeah, you can hear me, doctor. I'm audible.
yes, I can hear you.
Yeah, good. Because my internet is also sketchy. So, doctor, in this, I see in the skin biopsy, it shows. I can see parakeratosis. I can see what is. I think
So
it is follicular
only in the low
plugging.
power. Let
There's
us
a
not go into high
mild
power
degree of
picture.
psoriasiform hyperplasia.
Okay.
It's the cheek, right, doctor?
Yes.
So,
Go
okay.
ahead.
Yes. So at low power, I can see, yeah, at low power, I can see that there are quite a lot of sebaceous glands, maybe because it's the cheek. Then I can see that some of the follicles are plugged. Then there is some degree of elongation of the retirages. I don't know. Some
Okay.
degree, or is it normal in this location?
Okay. Go ahead. You just tell whatever you feel. No issues.
Yeah, that is at low power. When I go to high power, there is both alternating both parakeratosis and orthokeratosis. I can see both. There is a subepidermal infiltrate, a lymphocytic infiltrate predominantly. So these are my findings. Mild to moderate, mild degree of, you can call it psoriasiform hyperplasia.
Okay. Okay. So you think that the findings here suggest psoriasiform hyperplasia with some parakeratosis alternating with orthokeratosis, and there is a lymphocytic infiltrate in the upper dermis. So what do you make of these? I mean, before we go ahead to discussing the features, what do you make? What is your impression of this then? You said
To be,
psoriasiform hyperplasia.
to be frank, doctor, I work based on the clinical diagnosis given. So the other two diagnoses were, I think, vascular lesions. So I don't feel it's either of those. Though there are there is a lot of there are a lot of dilated vascular channels in the lower dermis, but I don't think it's a vascular lesion. Something based in the epidermis. Maybe it's
So
a
what
verrucous nevus.
do you think it may be a verrucous nevus? Nandakumar sir, are you there? We lost you.
Yeah, I think so.
I couldn't. The laptop got stuck. Now I am joining through the phone. I think it is. I'm audible, no?
Yes,
Yes,
sir.
sir,
Yes.
we can hear you. We can hear you. So Dr. Sharmina thought that there is psoriasiform epidermal hyperplasia with some parakeratosis and orthokeratosis, and she mentioned that sebaceous glands are prominent, but that may be because of the cheek site. So she thought that was because of that, and then she noted some inflammation in the dermis, which is fairly moderately dense in some places. And yeah, she was saying that given the clinical differentials, she would prefer probably an epidermal nevus.
Are we seeing you take into account the age of the patient also, and comment about the findings on the dermis, especially on the left-hand side the section? What do we see there?
The left-hand side of the section, sir, in the
This one,
epidermis.
this section, rather than that section, Dr. Nandakumar sir is talking about this section. So here there is a
Yeah.
lot of inflammation here, and as you say, there is more hyperplasia in this part
Okay.
of the section. But if you look at this section, the
Mhm.
hyperplasia is actually
Mhm.
fairly minimal, right? The epidermis seems to be of normal thickness here. Do you agree here? So here there is a bit of acanthosis.
Okay.
I'm not sure I would call
Okay.
it psoriasiform, but it is irregular acanthosis. Psoriasiform we generally use when there is
Mhm.
regular acanthosis. Here it's quite irregular. And the acanthosis is really restricted to the follicular infundibulum, to be honest. The intervening
Okay.
epidermis appears normal. Do you agree?
No. Okay. Okay. Yes, doctor.
So Dr. Nandakumar sir is actually asking you to comment on this section where the inflammation is lesser.
Sir, all I can say is that there appears to be an increase in the number of sebaceous glands in a lobulated. I don't know whether to comment that is normal in
So,
this location.
so one thing that
Maybe
you
it's not.
mentioned, Dr.
The
Nandakumar sir probably didn't
shouldn't have
hear you
so
when
much
you
of
were saying.
sebaceous.
Dr. Nandakumar sir probably didn't you when you
Mhm.
were saying. You said that you would go by the clinical. So
Yes.
actually, that is a very wrong way to approach a slide, because when you go by the clinical, what happens is you miss other differentials that are possible. So, and that is what, so generally what histopathologists or general pathologists do is that they pick one of the two diagnoses or three diagnoses that the clinician has given and say it is consistent with this. And that is probably
Yes.
one of the
Yes.
most
Yes.
annoying reports that a dermatologist wants,
Yes. Yes. Yes.
because they don't want the histopathologist to necessarily agree with the clinical diagnosis. And in fact, sometimes the dermatologist is stuck. They don't have a differential and they just give some differential that comes to a mind or some differential that comes to the PG's mind who's taken the biopsy. So often, as dermatopathologists, we are expected to think out of the box and give, something that they have not thought about, and that is very important,
Yes,
right?
sir.
In this case, you did mention the sebaceous glands, and so in what condition are sebaceous glands more prominent?
Sebaceous hyperplasia, nevus sebaceous.
Absolutely. So nevus sebaceous is what we are looking for, and why? So how do we differentiate? So the nevus sebaceous usually occurs in which sites? Do you know?
Oh, doctor, I knew long ago, not now.
So usually in the head and neck area is the commonest area. So these are areas where the sebaceous glands are anyway prominent, right? So the
Yes.
question that arises therefore is the exact question that you have in your mind. How do we differentiate normally prominent sebaceous glands from sebaceous nevus where there is more prominence of sebaceous glands? And the difference is that in sebaceous nevus, the normally sebaceous glands have to be attached to a hair follicle, right?
Mhm. Yes.
In sebaceous nevus, as you can see here, the sebaceous glands directly open into the surface. Can you see here? The sebaceous glands are, can you see my pointer on the screen?
Yes. Yes.
the sebaceous glands are directly opening into the epidermis, There's no hair follicle here. And that
Can
is
you
the,
move your pointer, doctor? Can you
can
move
you
your
see it
pointer?
now?
Good,
Can you
good,
see
good,
it
good.
now? So the
Good, yeah, I can.
sebaceous glands being directly opening into the epidermis differentiate. These are called immature sebaceous glands, therefore. Can you see this now in higher part? This sebaceous
Okay.
gland is directly opening into the epidermis instead of opening into a hair follicle. And these are called immature sebaceous glands.
Good.
These are placed much higher in the epidermis than you would expect a normal sebaceous gland. Normal sebaceous glands are present in the mid-dermis. This is present directly under the dermis, is almost in the papillary dermis. Okay? So
Come
this is
again,
an
doctor. Come
immature.
again. Come again, doctor. This is located higher up.
This is located higher up. It's an immature sebaceous gland because it's opening directly onto the surface.
Okay.
And normally, any sebaceous hyperplasia, any follicular sebaceous hyperplasia can be associated with a perifollicular lymphocytic infiltrate. This can be an inflammatory epidermal nevus or it can be an inflammatory sebaceous nevus. But inflammation within the nevoid lesion is common. Sometimes can happen for a number of reasons. Could be extravasant rupture of this, sebaceous material into the dermis, causing a foreign body reaction. So all these features. So generally, therefore, we discount the inflammation. You can call it inflammatory sebaceous nevus, but it doesn't actually change the diagnosis. It is in fact a sebaceous nevus. Now, you are right. So sometimes, I don't know, Dr. Nandakumar sir may want to comment on this. Sometimes it can be difficult to differentiate epidermal nevus from a sebaceous nevus because if you're only seeing this section does not have that many immature sebaceous glands as the section on the left. And therefore, if you're seeing only this section, you may be confused that this is an inflammatory linear epidermal nevus, an ILVEN. Given and often I think there is an overlap. Sometimes it may be difficult to distinguish both the entities and depends on which section you're looking at. Nandakumar sir, what do you think?
And it depends on the age of the patient also.
Yes,
Once
true.
the patient is older, we may not see all the classical features of nevus sebaceous. What we will be seeing would be only that of the epidermal changes, which is consistent with an epidermal nevus. We may find it difficult to, at that point, to label it as nevus sebaceous.
Yes, sir. Yes, yes. So, I mean, the important thing is to recognize it's a nevus. Nevus sebaceous is the right diagnosis here, but if somebody is looking at the section on the right and calling it epidermal nevus, I mean, technically it is not true, but there is an overlap. But in this case, I would expect the diagnosis to be sebaceous nevus in this case. What do you think, sir?
Yes, with the especially with the section on the left-hand side, there should not be any problem.
Yes.
As you rightly said, the most important thing is to identify it as a nevus and not to call it as an inflammatory dermatosis. That is the crucial point.
Yes. Absolutely. And inflammation here is part and parcel of a nevus. Sometimes nevi, even benign melanocytic nevi can have some inflammatory changes sometimes. And we need to be able to discount that given the clinical history and everything. We have to take that into consideration,
And even
especially.
in the history also, you have said that it bleeds with manipulation and all. That would
Yes,
have led
yes.
to the inflammation, no?
Absolutely, absolutely. Yes. So we'll go to the marking quickly. Go ahead, Dr. Sharmina. You have any other questions?
Yeah, so sir, just to know, what will be the treatment? It's excision.
Yes, yes. Excision is the treatment for it. I mean, the patient, I think this was an excision specimen itself, but the tumor is present at the margins. So yeah, excision usually is what is needed. I mean, it's probably just out, but yeah, excision is a treatment for this. So, right. Let's go to this thing, the marking. So I'm surprised a lot of people, the 34 answers in total, a lot of people, a majority have called it circumscribed lymphangioma. I don't know why actually, because there's no feature to suggest lymphangioma. I'm not even sure why that particular diagnosis is even. Maybe because there are some vessels are prominent here, but they are fairly minor vessels. I mean, I don't know why they've called it lymphangioma. These are capillaries also. They're not even lymphatics. And capillary ectasia with this amount of inflammation is expected.
How many people have got it right?
So nevus sebaceous 7 out of 34. A lot of people have called it inflammatory linear epidermal verrucous epidermal nevus. Shall we give that some marks, sir?
Yeah, we
It's
can
not-
give some credit for that. But in this case, I would expect a diagnosis of nevus sebaceous.
Yes, yes. How much shall we give? 0.25, 0.5? What is your feeling?
0.5.
0.5. Okay, fine. And nevus sebaceous here is there again. It's the same thing. Sebaceous carcinoma, 3 people have called it. I don't know why. Cavernous lymphangioma, sebaceous hyperplasia. So it's not sebaceous hyperplasia, but because again, you don't see immature sebaceous glands. So that's why it's not sebaceous hyperplasia. Irritated nevus verrucous is, I don't know why that kind of diagnosis came up. Linear epidermal nevus, again, that's if you're giving that, then 0.5 for this as well. Folliculosebaceous cystic hematoma, that's an entirely different entity. I think we need to show pictures to explain why it is not that. No, sir?
I think it is that person may not be aware about this particular entity. That is why
Yeah. So
chose to.
Yaddison's, yes, yes. Yaddison's nevus is same as nevus sebaceous, so we have to give that full marks. So sebaceous trichofolliculoma again is different. That we have to discuss. The adnexal tumors maybe in a different thing to understand why this is not sebaceous trichofolliculoma, because unless we show pictures, it's difficult. So people who are actually who've mentioned sebaceous trichofolliculoma, go on to the internet, see all different adnexal tumors. Ackerman's book is there on adnexal tumors. That's excellent. I mean, that's available on Amazon. You can buy it. It has got nice, excellent illustrations of all the adnexal tumors. So somebody who's wanting to learn about diagnosed by silhouette of adnexal tumors, that's an excellent small booklet, book actually, not more than 100 pages. Excellent black and white illustrations. So please go through that. So I'll finish this marking here. So we're going to case number 2 now. Case number 2 is very easy actually. 39-year-old male complaining of tiny skin-colored raised lesion displayed on the body for 2 years. Asymptomatic, gradually increasing number. DD was milia or xanthoma. And you can see here these tiny, small skin-colored papular lesions. And here on the neck as well, both sides you can see this. Dr. Sharmina, did you find this easy or difficult? I mean, this was not, we don't have scanned images for this. We have individual images. But maybe
Yeah.
we can start with the low power image and then we can go on to the next image. What did you think of this?
Yeah. So the epidermis looks pretty normal, and in the upper dermis, very superficially, I can see cysts lined by flattened epithelium, flattened squamous epithelium. They contain some sort of eosinophilic material. I couldn't describe the eosinophilic material in any way, but looking at the clinical picture and the histological picture, milia, eruptive milia.
Can I interrupt? Actually, you can describe the content of the cyst. Is it a homogeneous material?
Yes, sir.
No, it is not a homogeneous material. You are seeing a flaky kind of material inside. No.
Okay.
Can you make out the flakiness and
No,
see?
flaky.
That conveys what the material is.
Okay, keratin, sir? No, sebaceous secretion.
It is not sebaceous secretion. It's keratinous material.
Okay, sir.
Right. Describe the lining.
The lining is flattened, stratified squamous epithelium, sir. I couldn't make out the layers very clearly, but it looks like flattened squamous epithelium.
Here you can see.
Am I audible, sir?
Yes.
I couldn't make out a proper granular layer or anything, but overall it looks like flattened squamous epithelium.
Okay. Nandakumar sir, what do you think?
What else you are trying to focus on the adjacent dermis? Few glandular structures are seen there. Basically, it looks like an epidermal cyst.
Yeah, I can. Well, now that you say, sir, I can see occasional glandular structures nearby.
Yeah, that is a pilosebaceous unit. The cyst as such, I felt it was an epidermal cyst.
Okay,
Sasi.
sir.
Yes, sir.
So
So
clinically, yes, okay.
yes, sir. So this when we are looking at lesions like this, two things that we look on low power is whether the cyst is rounded or whether it's collapsed. So here it's slightly collapsed here, which gives you a slight clue. And the second thing what we look for is the presence of sebaceous lobules within the lining or just adjacent to the lining, which are absent here. So normally, when we're looking at these sort of cysts, epidermoid cyst is milia is really an epidermoid cyst, a small epidermoid cyst. Milia, it's a similar, both are similar entities in my opinion. Now, when we're looking at this, the other differential is a steatocystoma. When we're looking at, especially when somebody has got multiple, we have to look at steatocystoma multiplex. Now, to diagnose steatocystoma multiplex, we generally need to see that normally they have a slightly granulated epithelium, and also they have sebaceous lobules either attached to the unit or slightly adjacent to it. But these sebaceous lobules are actually quite far away. These are not related to this cyst. But actually, I mean, this is a practical thing I face. Nandakumar sir, you can maybe give your opinion. I mean, given the entirely flattened epithelium, which I mean, there's no apocrine secretion. These don't look like apocrine. This looks like flattened epithelial cells, keratinized epithelium. I mean, there is lamellate keratin, which can also be seen in steatocystoma, because often these are we see hybrid cysts as well, which sometimes they're not entirely straightforward. I felt this was, even though you're not seeing a sebaceous lobule, I felt given the clinical history, especially multiple lesions, I felt this was more consistent with steatocystoma multiplex rather than milia. Though I entirely agree with you, or a milium, or rather than a milium cyst or epidermoid cyst, I felt that. But given the histology alone, you can call this just an epidermoid cyst, but often there is an overlap. There are hybrid cysts, there often overlap. Sometimes you see both, sometimes you do biopsies. One shows epidermoid cyst-like features, one shows steatocystoma-like features. To me, the clue is this collapsed epithelium. Normally, this collapsing is not seen in milial cyst or epidermoid cyst, in my opinion. But would like to know your opinion, so that's why I put this case.
And these things can coexist also.
Absolutely,
One may be a steatocystoma and the other may be an epidermoid cyst. So
yes.
it depends on which one you have biopsied. Clinically, I also feel that looking at the size of the lesions and multiplicity of the lesions, steatocystoma is a distinct possibility. I do agree. Yeah, and I think our guest would like I hope you are aware about the tricholamel cyst also, isn't it? How does a tricholamel cyst differ from an epidermal cyst?
Sir, tricholamel keratinization. There is no granular layer, sir?
Yeah, there is no granular cell layer. It undergoes tricholamel keratinization. Another clue for a tricholamel cyst is the nature of the keratin. In the classical tricholamel cyst, we get compact keratinous material, unlike this flaky kind of material seen in this cyst. So that is also a differential when you look at cysts of the skin, right?
One doubt, sir. Steatocystoma doesn't. I remember. Doesn't it have a sort of a wavy lining, a wavy pink lining? No, steatocystoma.
No, that was what Dr. Sasi was saying. When this collapsed appearance could be the beginning of the wavy. These are all evolving.
Okay. Now I understand. Good.
So that is where we are getting at. So let's go with the marking now. Any other doubts, Dr. Shaimina, you have?
No.
You okay for us
So
to go ahead?
we would sign this out as how, sir?
So based on the clinical, I gave a descriptive report and said this is not, features are not entirely classical, but based on the clinical photographs, you have to hear, I mean, though they've only mentioned milia and xanthoma, the clinical also did mention steatocystoma, it's only my case. but I wantonly excluded from the quiz because if I mentioned it, people would make a diagnosis. But based on the clinical history and all, I called it steatocystoma, consistent with steatocystoma multiplex, but I wouldn't penalize anybody for calling it a milia or multiple epidermoid cysts, but multiple epidermoid cysts do not exist. If at all you want to call it, you can call it milial cysts. These are tiny milia, tiny epidermoid cysts are called milium. That's the only difference. To me, if you're
So,
calling it multiple milial cysts, then I guess you can, but the entity generally does not exist. Multiple milial cysts on the neck and this area, they are clinically, these are steatocystoma multiplex, to my opinion. So would you diagnose multiple milial cysts or multiple epidermoid cysts in this case? What would you call this actually? Based on
I would
CPC?
call it multiple epidermoid cyst.
You would call it multiple epidermoid cysts. Okay, right. So there you go. I signed out as steatocystoma multiplex, but if somebody wants to call it epidermoid cyst based on the histology alone, it's fine. I don't have a problem because, as Sir said, we know that they exist together. And if you biopsy a different lesion, it may show the classical sebaceous glands in the lining and the crenulate epithelium. And it's all a spectrum. So it's important to realize, what they are. And the treatment does not differ. Whether we call it steatocystoma multiplex or multiple tiny epidermoid cysts. If somebody, you have to reassure the patient's benign and you cauterize them or you use radiofrequency to treat the tiny lesions or reassure and leave them alone. There's no other treatment to it. So your labeling does not change the management. That's important. So a lot of people have called it eruptive milia.
Dr. Sasi, if you could give me 5 minutes. Yeah. 5 minutes to pray while you discuss the marking. I'll pray and get back.
Sure.
Minutes,
Please go ahead. I think, yes, go ahead. So a lot of people have called eruptive milia, which will get 1 point. Eruptive vellus cyst is a clinical differential, but then there is no hair in the thing. So I don't think we're giving any marks to that side. Do you agree? Nandakumar sir, are you there?
Yeah.
So no marks to that.
Yeah, can we look at the marks?
Yes, so eruptive milia, we're giving 1 mark, but eruptive vellus hair cyst, I don't think we're giving any marks because there's no hair. The differential between...
There is no hair. We cannot... That's exactly the point. We cannot diagnose vellus hair cyst with this.
Yes,
No
absolutely.
No mark.
Apocrine miliaria is a completely different condition, and that is not this. Steatocystoma multiplex, as I said, that is a CPC diagnosis, and I don't have a problem giving it full marks to that because they're part of the same spectrum. Right. Somebody has called it epidermoid cyst. Again, as you said, that can be given full marks.
Full marks, yeah.
Tricholemal cyst is a 0 because, as we explained, that is not tricholemal characterization, and that is not tricholemal cyst. Milia is in the same spectrum, so yes, give that full marks. It is not circumferential lymphangioma. It is not acrine hydrocystoma. Acrine hydrocystoma, I think that's an interesting answer.
I think, if I remember correctly, it shows apocrine cells also in the lining epithelium.
It's an apocrine hydrocystoma. Usually it should have some. That's why they call it acrine, I guess.
Yes.
Normally, the secretion acrine hydrocystoma is more homogeneous. You see the...
Yes. I don't think we can give credit for that.
Okay. His internet connection seems to be off. Okay. Can you hear me?
Yeah, I can. I think there is in between. My laptop got stuck. Nothing is happening with the laptop. I am not even able to switch it off. I don't know what happened. Now I'm actually doing it from my phone.
Okay. No problem.
We had started off well. The Zoom was on. You are about to make it into the full screen. Then the laptop got stuck. I think some technical problem with the instrument as such, not a net issue. Even the cursor is not moving.
Okay. You can see me now. You can see and hear me through your phone.
Yeah, I can.
Okay. So I believe we have Dr. Saurabh here as well, who's joined the meeting as a guest. Dr. Saurabh, are you there? Dr. Saurabh?
Yes, sir.
Yes, Dr. Saurabh. Do you want to quickly introduce yourself, switch on your camera and introduce yourself, and we can go through the next case?
Hi, sir.
Hi.
Sir,
Welcome.
good evening to everybody, sir. I am Dr. Saurabh Raut. I am actually MD dermatology. So I am working as an assistant professor here in Chhattisgarh, Raipur, in a
Oh,
private medical college, sir. And I have done my 1 year Dermpath fellowship from BMC Bangalore.
nice. Excellent. So you were one of the toppers in the last time's quiz as well. So that's good that you're here. So we'll go to the next case, Dr. Saurabh. Since Nandakumar sir, since your internet and this thing is a bit iffy, maybe you can just chip in with the discussion. I don't know. Are you able to see the images and all clearly, sir? Nandakumar
Yeah,
sir?
but I will also contribute. We can just go ahead. Let him describe the third case. We'll start
Okay. So this is the third case, Dr. Saurabh. So we'll go through it with you together. So this is a 56-year-old male who presented with complaints of annular plaques 14 years ago, which completely resolved, and now presents with similar complaints of 14 days, lesions involving the legs, abdomen, upper arms, ears, erythematous annular parts with surface scaling noted on the anterior and posterior aspects of legs, smaller lesions on the abdomen, arms, and forearms. Differential diagnosis of pustular psoriasis, chronic plaque psoriasis, and tinea. So I have to mention, this is the clinical. So you can see this here, erythematous scaly plaques, and on the feet as well going on. And these are more and more papular lesions on the forearms. And yeah, this is the same thing, close-up of the leg image. So, Dr. Saurabh, maybe you want to look at the low power and describe the findings, and we'll go higher power. Is that okay with you?
Hi, sir. So the specimen shows epidermis and dermis. So in epidermis, sir, there is hyperkeratosis, parakeratosis, collection of some pycnotic neutrophils at places.
No, don't go to higher power image features. Let us just discuss low power, and then we'll go higher power later.
Sir, in the low power, sir, it is just hyperkeratosis, the presence of epidermis and dermis, and there is hyperkeratosis, which is which can be seen in the low power. And some inflammatory infiltrate appears to be there in the superficial perivascular region and in the papillary dermis. Rest of the dermis appears apparently normal in the low power, sir.
What about the epidermis? What about the thickness?
Sir, it appears thickened, sir. There is acanthosis and associated with parakeratosis, sir. Associated with hyperkeratosis.
Would you want to qualify the acanthosis, or would you just say acanthosis? Would you call it regular, irregular?
It is irregular acanthosis.
Irregular acanthosis. Okay, fine. So this is the higher power. When we're going higher power, now you can describe the features in a bit more detail.
Yes, sir. So there is a confluent parakeratosis, and at places there is focal parakeratosis, and there appears to be some pycnotic neutrophilic collection.
Okay, you may want to stop me where you see the neutrophilic collection.
Sir, the opposite sides, sir.
Opposite side. Okay. Where do you think
Sure,
is the?
sure. I think we need to display.
In the center above.
Sorry, where? Stop me where you see it.
Sir, here above.
Here. This bit? You're talking about this blue bit? Or
And
you're talking about these ones?
Yeah,
sir,
on the
this one,
left-hand side, you can see.
yes, sir.
On the left-hand
Yes,
side.
sir. This one,
Left-hand side.
and
Yeah, yes.
yes, sir. Some more left.
Move it
Opposite
a
more.
bit to the left-hand side. Yeah,
Here,
yes.
here. Yes, sir.
Yes. Okay.
And some spongiosis of the parakeratosis has hypogranulosis, then spongiosis and some lymphocyte exocytosis is there, sir. And dermis shows moderated dense lymphocytic infiltrate in perivascular region, and erythrocyte extravasation also.
Erythrocyte extravasation, maybe we'll have to go to that.
Sir, others, sir, here.
Yeah,
Yes, sir.
some
Here.
erythrocytes are
So
there.
mild erythrocyte extravasation is there.
Yes. So, can you just summarize the findings then, Dr. Saurabh?
Sir, parakeratosis, irregular acanthosis, spongiosis, perivascular lymphocytic infiltrate, mild erythrocytic extravasation.
What about the granular layer?
Sir, hypogranulosis, sir. Below
Hypo,
parakeratosis.
right? Okay.
Hypo, yes, sir.
So based on these features, what is your provisional diagnosis?
Uh, Sir, at one place, sir, I thought I have seen something like fungal element also. So, like a layer of pycnotic neutrophils and in between Sir, here, like where this,
This
no, sir,
one?
there's a slight here.
Yeah,
Right, sir,
this
where
one.
this shoulder is there. So,
Okay. So generally,
there,
sometimes very difficult on this one to say that unless you're seeing definite branching, when
yes, sir.
sometimes because of the differential staining of keratin, you can see some keratin elements actually staining much more than the other elements. So that time these can appear like fungal elements, but very difficult to diagnose fungus based on this.
No, no,
Um,
yes, sir. Okay.
it is a difficult thing to diagnose. So these look like fungal elements because the keratin itself, when it's thick, it can stain a bit more darker than the surrounding things.
Yes, sir.
So, and these are just right on the surface. So generally, if you're seeing the sandwich sign, it's
Yes, sir,
okay.
here. At this
Yeah,
place, sir, at where
yeah,
the shoulder is there.
yeah, I know what you mean. But on the surface, this one here you're saying,
Yes, sir. I
um,
have felt like we're just above the arrow, sir.
yeah, I can see what you mean.
Yes,
I do not think that is fungus personally. They
yes,
look a
sir.
bit.
Yes.
This looks like keratin, which is very darkly stained to me. Dr. Nandakumar sir, would you diagnose fungus or would you suspect fungus based on this?
No, I wouldn't.
Yeah.
It
This to
is
us is
only
not.
keratinous material.
Yeah, it's just keratinous material which is darkly stained. Okay. And be very careful because generally on H&E stain, fungal elements do not stain. That is the clue. Fungal elements do not stain on H&E. They in fact appear as empty spaces. So if you're diagnosed fungus on H&E stain, look for empty spaces rather than something that's stained. Does that make sense, Dr. Saurabh? Dr. Saurabh, are you there?
Yes, sir.
Yeah. So look for empty spaces,
Yes,
empty
sir.
linear spaces rather than something that's stained when you're looking on H&E stain. This is not a H&E stain. This is not a PA stain, right? In PA stain, if
Yes,
you
sir.
see that, then maybe you can suspect this is a H&E stain. In H&E stain, fungus appears as empty spaces rather than stained, stained, they don't get stained. Okay. So given
Yes, sir.
that, say, consider fungus as negative, what do you call this now? What is your diagnosis?
Uh, Sir, this is a psoriasiform reaction, sir. Psoriasiform as well as mild spongitic. I am thinking in terms of the contact dermatitis.
Okay. So it is important to remember. So that is why the history is very important. I said patient had similar complaints 14 years ago, resolved just 2 years ago, and then recurred in the last two weeks. So in acute psoriasis, it is important to remember that the features are not full blown. Clinically, if you're looking at this, would you call this psoriasis or not? Clinically, this is psoriasis. This is early psoriasis. It looks like this. You see erythematous plaques and you see scaling. Clinically, this is not tinea. See, look at these papular lesions. Normally, don't get papular tinea like this, right? And the
Yes,
sites are not also typical for tinea. Clinically, they suspected psoriasis. But because the patient was in remission for 2 years and they presented acutely, they did a biopsy again. This is early psoriasis. In very early psoriasis, the features are not full blown. You are seeing some neutrophils in subcorneum. You're seeing all the features of psoriasis, but you're not seeing the regular psoriasiform hyperplasia, which normally takes time to develop. If you're biopsying a very early lesion, gutted psoriasis, or you're biopsying very early chronic plaque psoriasis also, you may see a slightly spongiotic reaction pattern with some psoriasiform changes, which are consistent with acute psoriasis. So this is psoriasis clinically and histologically. You can safely make a diagnosis of psoriasis actually, but you're right. When you're seeing on histology alone, if you're seeing a mixture of psoriasiform and spongiotic features, you're right to think about contact dermatitis. But then you have to look at the CPC. Based on the CPC, this is early psoriasis. Nandakumar sir, have you got anything else to add?
Yeah.
Do you have any other opinion?
The clue to think about psoriasis is one, even though it is irregular acanthosis, it is bulbous. Second point is presence of neutrophils in the stratum corneum. The third point is the focal hypogranulosis. I wouldn't consider contact dermatitis here because the infiltrate is not that many. In allergic contact dermatitis and all, you get a very busy dermis. No, here the infiltrate is very sparse, and we can make out few dilated capillaries in the papillary dermis. So, as Dr. Sasi said, diagnosis of an early lesion of psoriasis can be made with this much histopathological findings. A good case for discussion. How to differentiate it from the other spongiotic conditions and all. We cannot call this as an eczematous dermatosis. That is the crucial thing. There is not that much of spongiosis. Only a very tiny focus of spongiosis. What is striking is the presence of parakeratotic neutrophilic collection and the bulbous acanthosis and hypogranulosis. These three satisfy the criteria to make a diagnosis of psoriasis.
And also what is important is that the parakeratosis is disproportionate to the spongiosis. Normally in spongiotic dermatosis as well, we see parakeratosis. Here, the spongiosis is minimal, but the parakeratosis is much more marked. And this is a clue to the diagnosis of psoriasis rather than a spongiotic dermatitis.
Let us see the answers. Yeah.
Yes, sir. So case number 3, psoriasis vulgaris, a lot of people have called it. Some people have called it tinea. I don't know why. I mean, that's certainly a histological differential when you're seeing a psoriasiform dermatitis in neutrophils. But then you have to also go by the CPC. I don't know. Do you want to give some answers to that, sir? Because psoriasiform dermatitis in neutrophils.
One thing, we should offer a diagnosis of psoriasis in this case only after CPC. That is also important.
Mm.
No, I don't think we can give credit for tinea.
Mm. So especially since we don't have any demonstrable hyphae and we've not given anything else, we're not sure if PA is positive. Pustular psoriasis is a clinical differential. That is what they mentioned. And I mean, there are not enough pustules, but to call it, I mean, I guess you can. I mean, clinically, they said some pustules are there. So I guess if you want to call it pustular psoriasis, it's not the end of the world. What do you say, sir? Shall we give it marks?
We can give 0.5 marks. The thing is the pustules are not that prominent to give
Yes,
it
to call it pustular psoriasis. Yes. Okay. Erythema analyzed centrifugum, I don't know why that even came into the differential.
No.
Psoriasiform dermatitis is a non-specific dustbin diagnosis. I don't think we can give that any answers, any marks, in my opinion. What do you think, sir?
No, nowadays there is a tendency to sign off. I do see many reports with a sign of diagnosis as psoriasiform dermatitis. I don't know what does it mean. We shouldn't encourage that terminology at all.
Yes. Ankle psoriasis, I mean, it's not really, I mean, psoriasis fair enough, but acral psoriasis, I don't know why they called it that.
No, you cannot call this as acral psoriasis because
Yeah.
the epidermis is not that of an acral skin.
Yes, it's not even acral skin, so I don't know why. Granular parakeratosis, subacute spongiotic. Gutted psoriasis, again, I don't know why they call it gutted. I mean, I guess some of the papules on the arms, forearms, are slightly gutted, but this is not gutted psoriasis.
It is not gutted psoriasis, but can give 0.25 for making a diagnosis of psoriasis.
Yeah, I guess in that case, you have to give acral psoriasis also 0.25.
Yeah.
Okay, we'll give them 0.25, both of them. Eaton contact dermatitis, no pustular parakeratosis, I don't know what that is. Disseminated DSAP, PRP, no, unfortunately. I don't think we're giving anything else. Erythroderma, this is not erythroderma by any means. So I don't think we're giving any marks to that also. In fact, we have to give a minus mark for erythroderma because that's an acute emergency.
That person got carried away by the clinical picture.
Yeah. Okay, fine. So case number 4, Dr. Saurabh, you can go to case number 4 as well because, we only discussed one case. So this is a female patient with the history is severe itching and burning sensation in vulvar region for 6 months. diffuse erythema and atrophy of the labia minora with superficial ulceration, DD, gentle lichen sclerosis. So I guess clinically you can think about lichen sclerosis here. There's a whitish patch here. Oops. You can see that here. And maybe there's a tiny erosion there. It's on these sides. So this is the histology, Dr. Saurabh. Maybe you want to, yeah, you can. This image also is good enough. But do you want to describe it? Low power, and then we can go high power.
Yes, sir. Here we see sir, skin tissue with epidermis and dermis. So, one minute, okay. So yes, sorry, sir. So, like skin sample is there, which is having epidermis and dermis and deeper dermal tissue. So, in a lower power, we can see like upper layer of the epidermis appears to be paler, which can be expected, which is expected in mucosal glycogenation of the epidermal tissue, and dermis appears relatively homogeneous.
Okay, so we're going higher power. Do you think the dermis, the pathology is in the epidermis, dermis, or there's no pathology? So we want to describe. So when you say glycogenation, you're referring to these clear cells in the epidermis, right?
Clear cells in the epidermis, in the upper layers, yes, sir.
Yeah. So example here, you can see that nicely in this section. There are these nice clear cells, and these are usually glycogen cells. And
Mucosal epithelium, the appearance of the mucosal epithelium.
yes. This is not necessarily abnormal. You see that in mucosal epithelium. What about anything else happening here, Dr. Saurabh?
Lymphocytic exocytosis is there, sir.
Yes. Lymphocytic exocytosis there into the epidermis. Not much spongiosis, right? It's very focal. If at all the spongiosis is very focal, confined to this. You don't see desmosomes, and you're not seeing much of spongiosis here. Though these glycogen cells are there, again, these are just the cells are expanded, but you can't really call this spongiosis here. Anything else? Anything else in the dermis?
What about the basal cell layer? Does it appear intact or?
Basal layer appears intact, sir.
Right.
Dr. Sharmina, you are there as well. Are you back?
Yeah, I'm back, sir. I'm
Do you
back
have
since the
anything
last
else
week.
to add?
The subepithelium, it appears, I think, hypocellular, or is that just a feeling?
Hypocellular, I'm not sure I would call it that. What?
Cellular, no.
See, lack of cells is okay, right? I mean, if there are inflammatory cells, we would call it pathological, but if there are no inflammatory cells, it's okay. We don't need to be any inflammatory cells, but there are some mild deficiency input in the papillary dermis. And what you're seeing here is these ectatic capillaries, right? Can you see them?
Vessels, yeah.
And these ectatic vessels, are they pathological or are they physiological? That's the next question.
They're pathological.
Pathological, Dr. Saurabh? Pathological or physiological? These ectatic vessels. Are you there?
Pardon, sir. Can you repeat the question, sir, please?
Are these ectatic vessels? Can you see these blood vessels here? Small
Yes,
capillaries.
sir.
These
Yes, sir.
ectatic capillaries, are they pathological or are they physiological?
So they are physiological for the mucosa, sir.
You think they're physiological for the mucosa. Okay. And what about the nature of the collagen and the lamina propria? What do you think? Pathological or physiological?
So collagen appears very fine and delicate, sir.
Yes. With a bit of edema in between the collagen bundles, they seem to be a bit loosely separated, right?
It does appear a little bit edematous. Otherwise, it is normal for the anatomical site, the nature of the collagen, isn't it?
Yes. So the clinical differential given is this genital lichen sclerosis? That is the question we have to answer. What do you think, Dr. Saurabh? Is this genital lichen sclerosis or not?
Sir, I don't think so, sir. This is very full form like genital lichen sclerosis, sir.
Okay. What about you, Dr. Sharmina? What do you think? Genital lichen sclerosis or not? Dr. Sharmina, are you there? Dr. Sharmina, are you there? Okay, we seem to have lost her.
Yes, I'm here, sir. I'm here.
Okay. Is this genital lichen sclerosis or not? That's the question.
Yes, I think it fits in with lichen sclerosis. The epidermis is, I've seen cases where it is much more thinned out, but overall, I think it fits in with lichen sclerosis.
Okay. Nandakumar sir, what do you think?
No, I wouldn't diagnose LSA with this. No.
Yeah, very difficult to diagnose LSA with that. Clinically, that's what the question they've raised. And given there is vitiligo pigmentation, that is definitely a clinical differential. But there is no epidermal atrophy. In fact, it's hypertrophic, which you can see in early LS. But you're not seeing the collagen nature of the collagen. It's very loose and edematous. This you don't see in lichen sclerosis. There is no vacuolar interface change. The ectatic capillaries are actually physiological for the labia. Actually, they are normal. We should not diagnose them as pathological. And this edema as well, somebody who's scratching the area and for that tissue, it's normal. This nature of the collagen is normal for the mucosal tissue. In fact, even lip, you may see a similar collagen nature of the collagen. And this inflammation is probably secondary to them scratching or manipulating the lesion or doing something, but it's not, again, you won't actually diagnose a pathology based on this. There is mild inflammation. So this is, I call this non-specific vulvitis and left it at that without making a diagnosis lichen sclerosis, and said to the clinician that if they are suspecting lichen sclerosis, they need to take a biopsy from a representative area where the changes may be more full-blown, but right now the changes are non-specific. Nandakumar sir, what would you call this?
Yeah, I'll only give a descriptive report with this. Unless you have chronic inflammation, probably non-specific vulvitis. Whatever may be, sometimes the clinician would force you to give a diagnosis of a diagnosis which he or she feels that fits in, but we shouldn't be compelled to give that diagnosis. We cannot make a diagnosis of LSA with this. It's only a chronic inflammation. That's all.
So, given the history, severe itching and burning sensation,
Yeah.
would you maybe be compelled to call this vitiligo?
No, I wouldn't. I wouldn't.
Yes, because clinically it does not fit. Vitiligo does not present with severe itching and burning sensation, and you cannot vitiligo. Of course, the histology is non-specific, but no, I don't think that. I mean, I don't think that even the clinician is expecting a diagnosis of vitiligo. So yeah, I think the main thing is you should not diagnose LSA based on this, and 20 of them have diagnosed LSA.
I think that this is exactly what happens. When sometimes we get carried away by the clinical impression. We should be objective in our approach to the histopathology. That is important.
I think this is a case where we should have had negative marks, because because person who's diagnosed lichen sclerosis will get 0 marks, and everybody else also gets 0 marks. Unless somebody is calling it vulvitis NOS. This is the only person that's going to get 1 mark. Subacute spongiotic dermatitis, again, probably we can give that. I mean, that's a vulvitis. We can give that marks, I guess.
Yes, we can.
But Candida, vulvovaginal syndrome, hypertrophic, none of them will get any marks. So I guess that way we can differentiate these people from others. Zuhn's vulvitis, again, it is a vulvitis, fair enough, but Zuhn specifically refers to an NT where there's numerous plasma cells. So we cannot call that. What about lichen?
Again, a case for negative marking.
Yes. And somebody's even called it differentiate intraepithelial neoplasia. I mean, that is very difficult to call that neoplasia. I don't know why they got carried away. What about lichen simplex chronicus in this particular area in the vulva? I mean, generally we don't diagnose lichen simplex chronicus, but I guess they've not called it lichen sclerosis. in the absence of, I mean, they're not called vulvitis because maybe there's not inflammation, there's a bit of acanthosis. So they call it lichen simplex chronicus. Perhaps you should give that marks also.
0.25.
Maybe 0.5, sir.
Okay, okay.
Okay. So, right, we'll submit that. 3 more cases to go. It'll be quick because you're at half an hour. Okay. So next case, Dr. Sharmina, you may want to take this. It is a relatively easier lesion because we already dealt with something similar earlier. 14-year-old female, look at the history. Skin-colored verrucous lesions in linear distribution below the right axilla. Are they viral warts is the question. 14-year-old female. And you can see the linear distribution of lesions and you can understand why they call them warts. They're warty in nature clinically. Quite warty. Individual lesions, you can call them a wart without even looking at them, but they're quite grouped together. And this is the histology. So Dr. Sharmina, what do you think?
Yeah, Lopar. You can't call it the epidermis. You cannot call it papillomatosis. No.
No, you're quite right in calling it papillomatosis. This is papillomatosis. Nothing else can be called papillomatosis if this cannot be. This is papillomatosis.
But sir, the epidermis itself is flat, isn't it? It needs to be, no?
No. This is
It's just
papillomatosis. See how the epidermis is going up and down? This is papillomatosis. How else can papillomatosis?
But there's a core, no, sir? Still, it is called papilloma. My understanding was that it's...
Absolutely. This is what papillomatosis is.
Okay. So papillomatosis, and there is, on higher part, there is a degree of coilocytic change. I can't hear. On high power, there is a degree of coilocytic change, viral cytopathic change. So I think it could be called viral origin.
Okay, Dr. Saurabh, what do you think?
Sir, this is papillomatosis with a pigmented basal layer which is intact. I think, sir, the halo which is seen around the nucleus is the processing artifact. I am not very, sir, I don't think it is coilocytic change. Coilocytic change should be seen in the just near the upper epidermal layers, in the granular layer, but in the lower layers, and this is, sir, processing artifact.
Dr. Sharmina, what do you think now? Do you want to contest that?
I don't know, sir.
Okay, if you're calling it a viral wart, generally what other changes should we see? Apart from coilocytes, what are usually coilocytes associated with? What are the other clues to tell us whether these are coilocytes or not? What other changes in the epidermis do we normally see?
You can see changes in the cytoplasm also. That is not seen here. We see racinoid nuclei, and that is not very evident here. That's true.
So nuclei are much more
clear
pycnotic. Nuclei become pycnotic, hyperchromatic, and push to one side. And what other features? What about the granular layer normally in a viral wart?
The granular layer is much more pronounced.
Yes, absolutely. So unless you're seeing hypergranulosis, Dr. Saurabh is completely right actually here. Unless you're seeing hypergranulosis and associated with that in the top layers of the epidermis, if you're seeing coilocytes associated with that, those are true coilocytes. These are pseudocoilocytes. These are not true coilocytes. That's exactly the reason why I put up this case. Normally, you don't see this diffuse cytoplasmic clearing throughout the specimen. And this is not coilocytic change. In no viral wart would you see this diffuse change. When you're seeing such a diffuse change in the cytoplasm, this is artifact. This is not a true change. Does that make sense?
Yes, so true coilocytes, how is the distribution, sir?
They're usually in the upper epidermis, just below the granular layer, associated with the granular layer. And there's usually much more acanthosis and hypergranulosis. Where is the hypergranulosis here? There's no hypergranulosis here. There is no, the granular is there, but it's normal. This is not hypergranulosis. The keratohyalin granules become much more prominent. You can see the individual granules in a viral wart. Here, this is normal hypergranulosis. This is normal granular. This is not hypergranulosis. Okay? Nandakumar sir, do you have anything to add?
Yeah, see, two things. We should be very clear in the understanding of what is papillomatosis. Papillomatosis is essentially elongation of the dermal papillae upwards, pushing the epidermis upwards. It is actually a change occurring in the papillary dermis, which is reflected in the epidermis. So epidermis as such need not be hyperplastic to call it as papillomatosis. This is classical papillomatosis. You can see the papillary dermis going up, isn't it? Pushing the epidermis upwards. So this is classical papillomatosis. There should not be any confusion regarding that. Second, in viral wart, we get hypergranulosis along with very coarse clumped keratohyalin granules in the granular cell layer, which is completely absent here. And whatever vacuolated cells we are seeing is more towards the lower third of the epidermis. So this doesn't satisfy the features to call it as a viral wart. This is not chorocytic change. What else it could be? We have seen the clinical photograph.
Acanthosis?
No. Diagnosis.
Diagnosis, Dr. Sharmina. Are you aware of any other clinical entities which can present like this, with this clinical history? So as a pathologist, it's very important, therefore, you learn a bit of dermatology as well to diagnose this and not get carried away by what the clinician has told you, which is viral warts here. Dr. Saurabh, you probably know the answer. Dr. Saurabh, are you there?
Yes, sir. Sir, this is varicose epidermal nevus, sir.
Yes. So this is a epidermal nevus. So this is a classical linear epidermal nevus. Whether we call it verrucous or not, I mean, yes, we can want to qualify that. This is a linear epidermal nevus. Classical presentation, Dr. Sharmina. So don't get the clinical history. I mean, the clinical diagnosis way you go by the history, go by the clinical picture. But you need to have when we are reporting, we need to have all the differences in our mind. What could this be? And that's why clinical dermatology knowledge is very important for a reporting histopathologist. It's not just the pathology knowledge, because otherwise we won't be able to correlate. We just go with the one diagnosis that the clinician has given and we get sidetracked.
So, yes, sir. Yes, sir, perfectly. So, Nandakumar, sir, could you, the description of papillomatosis, could you tell me once again? The papillary dermis, it goes up, so that the epidermis
elongated, vertically elongated, pushing the overlying epidermis upwards.
Like this. I mean, the papillary dermis getting elongated in the sense, sir is describing the physiological change. Histologically, what you see, this is undulation of the epidermis that goes up and down. And you see these multiple follicular dells as well. You can see these, I mean, these dells, you can see that these small dells, all these dells are part of the papillomatosis. And that's a clue. It looks so irregular. Okay?
The epidermis, yes. The epidermis need not be thickened, right? It can be of the same thickness.
Epidermis essentially need not be thickened.
Need not be thickened.
But you see these troughs. Can you see these troughs? You see numerous troughs, and that's a clue. It goes up and down. It's wavy, completely wavy.
Yes.
Okay. Now we quickly move on to the answers because we've not got much time. So linear epidermal nevus gets 1 mark. Inflammatory linear epidermal. I don't know why they call it inflammatory. There's no inflammation here. Sir, what do we give this? Are we giving this some marks? 0.5, maybe?
0.5. 0.5. And I think Dr. Sharmila can appreciate the difference in the histology between the first slide that we discussed and this one.
Yes, sir.
Right. And why we called that as sebaceous nevus and this as epidermal nevus.
Verrucous nevus, I mean, yes, it's what they may not mention linear. Again, probably 0.5 for this side. Do you agree?
Yeah.
Okay. Verruca vulgaris, I'm not giving any marks for this. Blastoid linear inflammatory condition. Acquired nevoid epidermal nevus with hyperpigmentation. I don't know why they call it acquired, because 14-year-old male, very classical. So I don't know. Acquired, why acquired? I don't know. Do you think giving any marks? I mean, the called epidermal knee was fair enough. What do you think, sir, if you're giving others 0.25 or 0.5?
0.25.
0.25, yes. Okay. None of the others get any marks. Nevus sebaceous does not get any marks here. Acanthotic seborrheic keratosis is a very excellent differential diagnosis, but then clinically it is not that. So if somebody it's a 70-year-old male patient on the back and it's a single lesion, acanthotic seborrheic keratosis or seborrheic keratosis is an excellent diagnosis. Dr. Sharmina, can you understand the importance of clinical
Yes.
pathological correlation here?
Yes.
If it's an elderly male, single lesion on the back, not a linear lesion, seborrheic keratosis will have exactly the same features. It does not differ in any way, but this is not an acanthotic seborrheic keratosis. Somebody is calling that this, then we are not giving any marks. Okay, submitting this. So last two cases we'll have to go through quickly. We have got 10 minutes for each. So Dr. Sharmina, you may want to go through this, and then we'll give the last case to Dr. Saurabh. 54-year-old female, 6 to 7 months history of itching on the trunk, subsiding with topical steroids. They used a penta combo, which means a steroid, antifungal, antibacterial, everything else. Relapsing after a week gap, and clinical picture is not zooming in properly, but you're seeing some erythematous papules here actually. Very few erythematous papules on the trunk. Picture is not that clear here, unfortunately, when we're zooming up. I have to get that chart out. So patient has erythematous papules on the trunk, and this is the histological picture. I mean, it's not a classical image, but that's the whole point of the CPC discussion, because we want you to not make wrong diagnosis, and we want you to think of differentials. Maybe I'll give this to Dr. Saurabh. Dr. Saurabh, because Dr. Sharmina does not have the clinical knowledge to go with it. So this is on the trunk, on the back. I describe the images as erythematous papules distributed to the upper back and the chest. So that's what the lesions are. And they've used topical steroids. And this is the histological image. Dr. Saurabh, go through this one, and then I'll give the last case to Dr. Sharmina.
Yes, sir. So in low power, we see the epidermis and dermis, and epidermis appears relatively normal in this power, and inflammatory infiltrate appears to be more in the superficial dermis. And on going to higher power, it appears to be centered around the superficial blood vessels, with prominent with erythrocyte extravasation, but the infiltrate appears to be mononuclear or lymphohistiocytic. So, predominantly lymphohistiocytic, perivascular,
Are you using the
inflammatory.
histiocytes there?
Sir, sir, more lymphocytic mainly, and sir, few eosinophils,
So if you
sparse
mention
interstitial eosinophils.
yes, if you mention histiocytes, then the diagnosis will be completely different. So you need to be
Yes,
very
sir.
precise as to how you describe the histological inflammatory cells. If you're mentioning histiocytes, then your differential diagnosis widens to something else, right?
Yes,
And this cell is a
this eosinophil.
eosinophil. Dr. Sharmina, can you appreciate the eosinophil here?
Yes, sir. Yes.
Okay. But the infiltrate, as you rightly said, Dr. Saurabh, is predominantly lymphocytic. I mean, it is a purely lymphocytic infiltrate with an occasional eosinophil. Eosinophils are very, I think that's the only eosinophil that is probably there. I probably didn't even notice that in reporting, to be honest. Did you notice any other eosinophils, Dr. Saurabh?
No, sir, very sparse, sir.
Very sparse
Sir,
eosinophils.
yes, sir,
Yes.
some melanophages, but eosinophils are like very occasional, sir, very sparse.
Hmm. Um, Okay. So given this histology, leave alone the clinical history. Let us ignore that for the moment. What would you think could be the differentials based on this histology? So there's no epidermal change. There is only a superficial perivascular lymphocytic infiltrate. What entities and some extravasation RBC, occasional eosinophil, what entities come to your mind first of all?
Sir, like I would like to think in the terms of vasculitis, sir. So, lymphocytic vasculitis with eosinophil, so urticarial vasculitis, along with the erythematous, erythematous plaques, So I would like to think of, sir, arterial vasculitis also in this case.
So arterial vasculitis, you meant what is the nature of the infiltrate?
Sir, usually it is, sir, neutrophilic at the start, and after that it
Arterial
becomes.
vasculitis basically is a leukocytoclastic vasculitis presenting as an arterial patch clinically, but histology should show a leukocytoclastic vasculitis. Okay.
Yes, sir.
Here there is no
Lymphocyte.
leukocytoclasis. There's not even a single leukocyte. There are
Yes.
extravasation of RBC. So you mentioned extravasation of RBC even in the previous case. What do extravasation of RBC imply to you in your mind? Do they have changed your diagnosis or move you towards a different diagnosis? What is your understanding of interpretation of extravasation of RBCs?
Sir, prominent erythrocytic extravasation with damage to the vessel wall and presence of this erythrocytes more in the interstitium. So, sir, that what made me think of vasculitis.
No, that's not that. In this case, it's okay. In general, even in the psoriasis case, you mentioned extravasation of RBC, right? So what do extravasation of RBC actually imply? Do they always imply a vasculitis?
No, sir, it doesn't always imply vasculitis. So, sometime increased capillary permeation can also be there, and in some psoriasiform cases like sir, P. rosacea also we see extravascular RBCs.
So
So,
normally in my reporting, I don't give any importance to extravasation of RBC unless there is other associated signs to suggest the vascularity process. So extravasation of RBC can be seen in any acute inflammatory condition. Nandakumar sir, what do you think? Any comments?
Yeah, I don't think we should think about vasculitis in this histology. This is just perivascular infiltrate. Dominantly mononuclear perivascular infiltrate doesn't show features to call it as vasculitis. We have to be, again, very clear cut about what to call it as vasculitis. Otherwise, every other perivascular infiltrate would get called as vasculitis. This is not vasculitis.
And remember, Dr. Saurabh, there is the entity of lymphocytic vasculitis itself is a very controversial entity, and one should not really make the diagnosis unless somebody is seeing definite fibrinoid necrosis of the vessel walls, and that is the most important criteria to diagnose vasculitis with definitively. Of course, not all leukocytoclastic vasculitis have fibrinoid necrosis, especially in some cases, early stages or late lesions, you may not see that. But then you have to have a clinical history to correlate with that. Then we can say consistent with leukocytoclastic vasculitis when you're seeing nuclear dust, etc. Here, just based on extravascular IVC, one cannot really even think about. I don't even consider them in my different. I don't even consider the extravascular IVC when I'm actually making a diagnosis. I've ignored them totally. Okay. Dr. Sharmina, what do you think? What are what differentials? And Dr. Saurabh, think about the differentials you may think of. What differentials do we think of when we are seeing a perivascular lymphocytic infiltrate in the superficial dermis, and maybe sometimes if you're seeing deep involvement as well? What are the differentials we normally think of? Do we see this in psoriasis?
No.
Yes or no, Dr. Sharmina?
There are no other features of psoriasis, doctor.
No, but normally do we see these histological features in psoriasis?
No.
Even on the epidermal changes? No, right? Generally,
No.
in psoriasis, we don't see this amount of dense lymphocytic perivascular infiltrate. We don't see this often in eczema either. What other conditions do we maybe normally see this amount of infiltrate in the perivascular area, composed predominant lymphocytes, occasionally eosinophil? When we're seeing, maybe if you're seeing more eosinophils, what comes to mind?
Allergic drug reaction.
Allergic drug reaction, certainly, yes, one option. Though normally you often see some epidermal changes as well. Another entity? Papillary urticaria. Papillary urticaria typically presents with perivascular lymphocytic infiltrate, sometimes with eosinophils. Dr. Saurabh, do you agree?
Yes, sir.
And the other differences we need to think about is 5 L's. Normally, luz can present with this, syphilis can be syphilis, lupus. So all these drug reactions, lymphomas, these are the things we think of. But normally, that is when you have a deeper infiltrate as well. What about the other entity that I normally think of is polymorphic light eruption. In polymorphic light eruption as well, you see a bit of upper dermal edema. As you're seeing here, the collagen bundles are a bit separate apart. Can you make that out? Can you make this upper dermal edema, which you've missed earlier? Can you make this sort of this collagen bundles separated from each other?
Yes.
And there is a bit of an interstitial infiltrate as well, which you missed. So there is a perivascular and also an interstitial infiltrate with edema of the upper dermis. 1 or 2 eosinophils are there. And this pattern can also be seen not only in papillary urticaria, can be seen in polymorphic light eruption as well. The other condition that can mimic this is often Jessner's lymphocytic infiltrate. In milder early cases, it can present like this. Okay. So without looking at the history, this is the difference I think of. Dr. Nandakumar sir, do you have anything to add? This pattern, what would you think of if you're
No,
looking at that
in
light?
polymorphous light eruption, we could also find peri-adnexal infiltrate also.
Yeah, though you're not seeing adnexa in this. Right.
Right.
Yes. So this is a difficult case. I put this so that people don't misdiagnose it and call it something else. Given the clinical history, I put it under the patients use topical steroids as well, and 6 to 7 month history, lesions of trunk, erythematous papules. My first diagnosis was actually Jessner's, because Jessner's usually present and they've used topical steroids, so steroid modified. But then, this is not a straightforward diagnosis. I have to admit that. This is a condition where you give a differential diagnosis, wait for evolution of lesions, and then make up your mind. But I put it in the Jessner's ballpark. Papillary urticaria can be there, but again, the distribution of the lesions is not that of papillary urticaria. Usually, you have to see lesions of limbs to call this papillary urticaria. The single eosinophil, I'm not going to sway my diagnosis based on that. Nandakumar sir, what did you think? What was your diagnosis?
I mean, upper dermal lymphocytic infiltrate, predominantly perivascular. I would also call it perhaps as Jessner's lymphocytic infiltrate, but I would like to keep the patient under follow-up and even do a serological workup for autoimmune illnesses like ANA and all. That can be done.
Yes.
And even if facilities are there, we can do an IHC to see what the nature of the lymphocyte.
Yes. Though, I mean, this doesn't look like a lymphoma. Histologically, you expect much more denser infiltrate, right, sir? Would you do a IHC?
We do find, we do get to see this kind of histological picture once in a while. It's difficult to call it as a single entity, but can with the CPC you can perhaps offer a 1 or 2 differential diagnosis and then do some workup if needed.
Yes. So here is a case where, as a pathologist, you would be. It is important not to give a specific diagnosis, and like we discussed psoriasiform dermatitis earlier, it is a crime to give a diagnosis of psoriasiform dermatitis in a case where the CPC suggests psoriasis. But here
and not call it as vasculitis. Yeah.
Here it is important to to make sure you don't misdiagnose it, but also give a descriptive diagnosis with differentials, and that's how you would actually give this. It's difficult. This is a difficult case for a quiz to give this thing, but let's see what people have said. So a lot of people have called it lymphocytic vasculitis, and that it's a very vague entity, lymphocytic vasculitis. What do you think, sir? Should we give any marks to that?
No, we cannot. We cannot. That defeats the very purpose of the discussion that we have had. We cannot call it as lymphocytic vasculitis. We cannot give any credit for that.
Yes, yes. Pityriasis rosea, apart from extravasation IBC, there's no feature to call it pityriasis rosea.
No.
Contact dermatitis, again, there's no dermatitis. It's more of a perivascular inflammation. We contact lichenoid hyper, I don't know why they call it. Papillary urticaria is a good differential.
Yes,
Clinically,
yes.
yes, I think we should give that marks because that's a good
Yes.
diagnosis. I think
Yeah.
anything close, we'll give that full marks, sir. I mean, I think if
Full marks.
it's a differential, we'll give that. Atopic dermatitis, not. Erythema annulus centrifugum, yes, it's a very good histological diagnosis, but clinically, you cannot really call it erythema centrifugum because I've not given any history to suggest that they're annular lesions with central clearing. So,
Right.
histologically, it's an excellent diagnosis. Clinically, not. What do you think, sir? What should we do with that?
We can give 0.25.
0.25. Histologically, Dr. Sharmina and Dr. Saurabh, histologically, this exactly fits. If the clinical fits, this would have fit erythema annulus centrifugum. But this is not a clinical diagnosis. The CPC does not fit. I mean, because this is a vague, this is a descriptive case, we're giving it some marks. Subacute cutaneous lupus erythema should definitely be in the consideration. I think full marks for that because that depends on CPC. Do you agree, sir?
We are not seeing any interface changes.
No interface changes, but then you mentioned lupus, right?
Yeah,
You mentioned
I would like to work up the patient, but histology wise, we cannot call it as subacute lupus erythematosus.
You cannot call it, but then this is a CPC case. I think we should be giving some marks to it because
0.25.
0.25, sir. I would rather give 0.5, but if you want to
All right, I agree.
Because it's a CP, they have to do ANA to exclude it.
Correct. Okay. All right.
Okay, I'm not giving anything for this. Reticular erythematous mucinosis is an interesting entity because it's part of the lupus spectrum, part of the Jessner spectrum. Again, that is a very clinically distinct entity. I don't know. It can present with perivascular lymphocytic infiltrates. It's a good thought, but some marks.
I don't think so.
No, okay. No mucinosis. No mucinosis. Okay. PLE can be given some marks, but it's on a trunk. I mean, that's a clinical histological differential. I mean, if you're giving erythema annulus centrifugum 0.25, this can be given 0.25.
Yes, we can give some marks for this.
Yeah. Again, pleva, I don't think we give anything. Contact urticaria, I'm not quite sure. I mean, we can call it urticaria if the clinical fits, but this is not urticaria either clinically also. Petrospora, folliculitis, lichen planus. Jessner's have given, so I think that should be given marks. Jessner's was this thing. Superficial perivascular inflammatory dermatosis is very vague histology. It's a descriptive diagnosis. They didn't.
No, we cannot give any credit for that.
But that is the histological description, sir. They didn't misdiagnose anything else.
That is true, but there something has to follow that sentence.
Okay. Tibia, Govers, papillary mucinosis, tumidally named. We can't make tumidally. Urticaria, I mean, that's a very vague thing. Urticaria, what? I don't know. Okay, we'll finish it at that side. Do you want to give any marks to any of the others? Shall I submit?
Right.
Okay. So last case number 7. We'll quickly go through this. So Dr. Sharmina, this is a 71-year-old female, warty papilla on the scalp for 3 months, treated with shave excision biopsy. Probable viral wart was the his clinical differential. Now, here we've been talking about virus, we've been talking about epidermolysis, so I put them all together because it's very good to discuss all of them together to, get our minds and get a clear picture. So what do you think about this?
So on LOPA, there is an exophytic lesion. The epidermis is markedly thickened. If you go on to higher power, you can see
Just
that.
a second, Dr. Sharmina, would you call this papillomatosis? We discussed papillomatosis.
Yes, this is what is in my mindset. Definitely papillomatosis.
All that, Samala, let's be very clear. All that I said was that the epidermis need not be thickened.
I understand.
To call it as papillomatosis. That is what I meant.
Yes,
Right.
that is why, sir, I asked for your definition
yeah,
again. That is what I wanted to understand.
Here there is definitely papillomatosis. I think
Yes,
when you describe, even the hyperkeratosis needs to be mentioned. There is marked
yes,
hyperkeratosis is also
yes,
there, isn't it?
yes,
Right.
yes. So
Yeah.
that is what I wanted to understand, sir. That is why I asked for your definition
Yeah.
again. That
Yeah.
the
Yes.
description was very nice, sir. The papillary dermis is,
Yeah.
going up vertically, so lifting there. But that
Right.
is why I asked for it again. So in this
Yes.
case, there is prominent papillomatosis. There is also prominent acanthosis. There is a lot of parakeratosis. If you go on to higher power, you can see in the like sir asked me in the last case, there is quite a prominent granular layer. There are coarse keratin hyaline granules. It's predominantly it's more of an endophytic. There is an endophytic component also, very blunt lower edge. So I think I can safely call it a viral a water verruca vulgaris.
Yeah, you're right on this one, Dr. Sharmina. We got this one. Now you understand the difference between true coilocytes and pseudocoilocytes. You're seeing a
Excellent.
nice granules. You're seeing
Yeah.
the coilocytes here, right?
Yeah. So the coilocytes, sir, can you show me in high focus, sir, the difference between last time and this time?
So here you can
This is
see
zero
the clumped keratohyalin granules are associated with the coilocytes, and the coilocytes are restricted to the epidermis. In the previous
Okay.
case, the baccalaureate cells were seen in the basal layer and actually some of the cases throughout. Here it's restricted to the granular layer. Can you make that out? And the
Okay.
nuclei are abnormal, the nuclei are not normal, and you see this clumped, coarse, thick keratohyalin granules.
Yes, sir. The nuclear change, is it very obvious here, sir? I
The
can't.
nuclei, some of them are abnormal. You can see this here, see this here. Some of
Okay.
them are not so, but then they're associated. See, not
I
all
understand.
of them are evolved.
I
There are
understand.
different stages of evolution, but you're seeing this clumped coarse keratohyalin granule. That's the clue here.
Oh,
Nandakumar sir
The-
mentioned papillae being pushed up here in this case. I mean, for others who are listening, here the papillary dermis is not so pushed up. Here the papillary dermis, in fact, because it's an endophytic lesion, so partly the papillary dermis is pushed down, but we're still calling it papillomatosis. So your definition probably in this instance maybe needs a bit of changing. I don't know.
yeah. But it was a big eye opener for me, sir. The description. That's why I asked for it again. Nandakumar
this
sir.
is, this
Nandakumar
is,
sir. Yeah, you
yeah,
asked
please.
me to contrast case 1 and case 5. I think my net
Yeah.
was shaky again. So
Yeah.
can you tell me again, sir? Case 1
No.
you told me.
I just wanted to tell you the difference between a sebaceous nevus and a verrucous epidermal nevus.
Yes, sir. So I lost you. My net was shaky. So in case 1, there is more of acanthosis. No.
No. We are discussing about nevus sebaceous, no?
Mm-hmm.
Sebaceous nevus.
Yes, you asked me to contrast it with some other case. I think it was case.
The epidermal nevus,
No,
with the epidermal nevus. In the pure
epidermal
epidermal
Yeah,
nevus,
nevus.
there's no
yeah.
sebaceous glands.
Okay. That's all. Okay, sir. Good.
This is actually an endoexophytic lesion.
Yes, sir.
The lesion shows, in addition to papillomatosis, significant bulbous acanthosis also, isn't it?
Yes, sir.
Right. That may be the reason. That may be the reason why we are not seeing the elongated dermis pushing the epidermis upwards. That may be the reason. And the plane of the sectioning, perhaps.
Mm.
And one thing to remember is that the histology of a viral wart depends on the age of the lesion.
Yes.
The coarse clumped keratohyalin granules, coilocytes, etc., will be present only in the early lesion. If it is a very old lesion, we will only see features to call something as like squamous papilloma, perhaps.
I understand.
We may
Burnt
not,
out.
at that point, we will not be able to commit that it is a viral wart. But here, histology is sufficiently clear cut to call it as a viral wart. Dr. Saurabh, you want to add on to the description?
I want to
Yes, sir.
particularly somebody comment on this, Dr. Saurabh or Dr. Sharmina, what are we seeing here?
So there are this columnar parakeratosis with associated serum exudate, or
What
what
about this
we
brown
see as,
material?
yes, sir, this is erythrocyte, sir, due to just what we see as black dots in dermoscopy. So this is coagulated blood or erythrocytes, which is like which has gone outside from the capillaries
So this
and
is
then
hemosiderin.
incorporated to.
This is This is hemocyte, not actually, don't
Yes.
call it erythrocytes because you're not
Yes,
seeing a
sir.
cell.
Yes, sir. Yes, sir. Hemocyte.
So this is
Yeah,
typical of viral wart as well. You don't
Yes,
see
the
this in
columnar
other-
parakeratosis is a big clue to call it as a viral wart. Very good point.
You see this columnar parakeratosis. Excellent. So for lack of time, I think we'll stop the discussion there and
Yeah.
go to the marking. It's only 9:35. So Veruca vulgaris will get all the marks. Papillomavirus, seborrheic keratosis, what it is, I don't think we're giving any marks to any of them. Unfortunately, that's it. Only one question, one answer will get all the marks. Excellent. Well done, both of you. I think hopefully you have learned something and hopefully the session was useful. Dr. Sharmina and Dr. Saurabh.
Yes, sir. Yes, definitely.
Yes. Yes.
Excellent. Any questions before we end the session?
We
So,
enjoyed both of you with us. I hope you also benefit from the
Yes.
time spent with us.
Yes, sir. I
Yes,
have also
definitely.
learned. I have learned. So I have also learned a lot, sir. Thank you, sir.
Excellent.
Thank you very much, doctors. Yeah.
Thank you. Thank you, Glodama team. Thank you, Nandakumar sir. We'll wind up
Thank you.
session for tonight and see you again.
Bye.
Sir, there are the
Yeah.
3 questions in chat box.
Okay, okay. Let me go through them. Let me see. So where are the chat box? Okay. The first question, how do you differentiate between immature and mature sebaceous gland histology? I think we already answered that.
Yeah.
Immature ones open into the epidermis directly. Are there some extravascular RBC also at place? I think that was one of the questions. Yes, there may be that. As I said, we don't differentiate. We don't even take that into consideration. We don't really give much importance to them. Are the ulcers traumatic? I think they were referring to the lichen sclerosis genital case. Probably traumatic from scratching. I think that's the only case that we mentioned trauma. So yes, that may be just secondary to scratching, and the biopsy was taken from the non-traumatized area, I guess. So that's why you're not seeing the ulcer. So yeah, I think that should be fine. Rohit, thanks for pointing it out.
Thank you, sir. Thank you.
We'll call it a
Thank you.
day. Yeah. Good night. Good night.
Okay, good night. Thank you. Bye bye.
Thank you, sir. Thank you.
Thanks.
Thank you, sir. Good night, sir.
Good night.
Good night.